As we move into a conversation that truly pushes the boundaries of precision medicine, because as we spoke, that precision care is no longer confined to cancer, it is expanding into some of the most pressing health challenges of our time. So this panel focuses on precision beyond cancer, metabolic, infectious, and chronic disease. This is where the science meets scale, where genomic diagnostics and advanced therapies are being applied to diseases that impacts millions every single day. So from metabolic disorders to infectious diseases and chronic conditions, how do we bring precision into everyday clinical practice is the question. And that is exactly what this powerhouse panel is here to explore. To steer this conversation, I would like to invite our moderator, Dr. Deepak Modi, Scientist G, Department of Molecular and Cellular Biology, ICMR at National Institute of Research on Women's Health. Thank you so much, sir, for joining. Joining us for this exciting discussion, we have a dynamic mix of clinicians, researchers, and innovators, all set to bring the fresh perspective to this evolving scale. Dr. Sridhar Sivasibhu, Chief Diagnostics and Research Officer, Karkinos Healthcare. Dr. Hema Purandre, Founder, Center for Genetic Healthcare and Consultant and Medical Director at Prenatal and Reproductive Geneticist at MedGenome CGHC. So, ma'am, can we please have you on stage? Dr. Kanishka Jain, co-founder and director of Precision and Functional Medicine at Rhinomite. Dr. Ashim Mathan, co-founder and director at Advanced Recovery and Longevity Sciences at Rhinomite. Dr. Anjali Pai, Product Manager Clinical Genomics at Premas Life Sciences. Dr. Atul Thatai, Director Molecular and Cytogenomics at Max Healthcare, New Delhi. We have Mr. Ashim Mathan here, so please join us on stage.
Very good afternoon and nearly evening. A very warm welcome to my esteemed panelists who are here, and it's again a privilege to be on this dais. And finally, we'll move beyond oncology. I think those of us who are not into oncology probably had an overdose of cancer since morning because we've been just discussing about oncology. But I understand why, because that's where it's a forefront of precision medicine, and that's where we are learning a lot from them. And in this section, what we will see is how do we apply our understanding of precision medicine, our experiences from oncology into non-oncology segments. And our esteemed panel of members who are going to help us through discuss things. I'll just take the permission of the panelists that I may not really stick to the questions that have been posed here. Will be a little impromptu, a little spontaneous, and you can speak your mind out. I'm sure nobody is going to really mind a lot of things. So we know now that precision medicine is the buzzword. We have to move towards it. We have already moved towards it in India. And let's start with Dr. Sridhar Sivasibhu, who has been the forefront of precision medicine, or precision genomics in India to be more precise, who has been brainchild into having the Indian genomes sequenced. What do you see are the current contributions and of our understanding of the high burden disease beyond cancer? Where do you think we should put our foot forward first when we have to implement precision medicine? Or where do you think we have already put our foots into, and then let's look at in the future?
Thank you, Dr. Deepak, and it's always a pleasure to come back to Voice of Health, and thank you, the organizers, for the invitation. So coming back to the question, if you slice they take the narrow slice of cancer genomics away and then focus on what has already been done and what needs to be done. A few things come to my mind directly. One is over the last now 20 years that genomics has been in some shape, size, form in our country. That's from 2008, I would recollect. One of the biggest impacts has been in the rare disease diagnosis space. No questions. This has been practically implemented across multiple medical disciplines, no more restricted to a particular one to a particular domain. That thing, of course, is a good example to start with. The second thing that comes to my mind is reproductive health. Amazing strides. You can see mushrooming centers that now give very clean advices, right, from IVF to prenatals to many other conditions. That's the third is infectious disease. Of course, all of us witnessed COVID. We saw what COVID genome sequencing did. Almost we identified, I think, Delta, Kappa, and Delta plus Kappa, and Omicron right here in India, thanks to genome sequencing. So, and now it has gone to waste roster surveillance, unknown pathogens, multiple. But the foundation of all of this, where I think we are completely taking it for granted, is population genomics. People may think that we have done very little compared to what other countries are doing, but being at the government side for 20 years, having led many of this program, one of the thought process that we had early on was we would not have the resource to do a billion genomes. That's not feasible. But if you could look at the top 10 or 20 genetic diseases that ails our country, okay, and convert that into public health knowledge base or public health programs, I think in those parameters we have done very good, and you'll see some very amazing results coming out of many of the programs that the government is now implementing across the Ministry of Health, ICMR, DBT, CSIR, and so on organizations. I'll stop there. Thank you.
Thank you. Thank you so much. So we have a wonderful take-home message here that if we are not talking of cancer, we are definitely talking of infectious diseases, infertility, maternal health, and obviously rare diseases where precision medicine genomics is going to make the big impact. Let me move to Dr. Hema Purandare. Madam, I don't know if you remember, as a student, I've read your books. Probably we have met in some of these meetings, and I've been always inspired by the way you have started genomics in the country. And when you use the term genomics, we always think of the term NGS, but actually genomics, I truly believe, is karyotyping. And I think Madam was one of the early ones to start karyotyping in this country. And I understand the difficulties that you must have gone through in establishing that. And not just karyotyping individuals, but also offering prenatal diagnosis. So, Madam, what have been your experiences when you began? See, we are beginning now to implement genomics as NGS and precision medicine, but I'm sure we have a lot to learn from you of what were the difficulties and challenges you faced at that point of time in implementing, let's say, traditional genomics or genetics in India.
I'm glad that you asked this question. Thank you very much for keeping me on this panel and with these esteemed speakers. I would like to say, first of all, when my training in genetics, which was there after 3 years in US, and before that I was in Grand Medical College teacher, as you said. And though that training inspired me so much that I wanted to do something in the country. And first was Memorial Sloan Kettering Hospital. And being in the cancer panels today, I mean, listening to people, when I approached every single hospital, including government, saying that I want to start genetics in the hospital, wherever I was working at JJ Hospital. Ultimately, I don't want to say what transpired, but they said, genetics की तो हमें ज़रूरत नहीं है, आपकी हिम्मत होती तो खुद की lab निकालो. And that is why I decided, no, I want to do this, and I got out of my 15 years of service, and now 50 years I'm practicing genetics. Now the experience was first, like you said, spreading awareness. Those days nothing was available. Meeting from doctor to doctor, and good students and good people who understood a little bit of genetics and then their patients' trouble, especially in prenatal diagnosis, as you said, or Down syndrome babies, where recurrence risk is very important, because if you have first Down syndrome, unless you do karyotyping, you will not know what would be the recurrence risk. So child and the parent. Then it came to prenatal diagnosis. And then it came into screening now. Because before prenatal, now we are doing screening. And now we are into newborn screening. And as well as now we can do carrier screening if somebody wants to find out, or if there is already affected child, or any affected family member who wants to know what is their risk of passing it on to progeny. And then there came the genomics, which helped us a lot.
Thank you so much, madam. That was such a wonderful thing. Any advice for the students who are sitting here that you met with these challenges?
Yes.
How did you overcome them? What was that one burning thing that you had in you that you said, no, I'm going to get it done? I know you are a go-getter.
Facing challenges, of course, confidence in myself, my gurus who had taught me, and the need for our country, because I could never see any suffering. I've never wanted to take medicine, I told my father, who is founder of Borosil Glassworks. And he said, you have to become a doctor. I said, I don't want to become a doctor because I can't see any suffering. He said, then you will be the best doctors. And I thought genetics were where, because you know that still most of the genetic conditions, like there is no treatment, it is management, and only for the second child we can help. So this is how but I think good friends like yours, and there are so many, who understood the importance of genetics, and they made me address their conferences. And that is how I had to meet the challenges, training the staff right from glassware washing. But one thing I would like to see in medical that I always say, we have to come now from cadaveric dissection to genomic dissection if we want to understand and we want to help the patient, especially in medical students.
Thank you. Thank you so much. Very well said, ma'am. A single most company that I would single out who is responsible for getting genomics in India is Primas, who got Illumina to India. I'm not boasting here because I know them for a long time, but at least I'm sure, Sheeta, you'll agree to it, that our abilities to do genomics and that we can do it was because we had some providers, some wonderful providers who took the first leap that no, these technologies will be sellable in India, will be sold in India, and people will use it. That faith was there in Pramas, and I think really I applaud you for that you really took the big leap. What is the philosophy on which you began with this idea that India should have genomics and advanced genetic services? And what as a company was your philosophy? And what do you think is the future going to look like? Anjali.
Hello. Hi. I think I'm 1 year old in the company, so it's a great question to come to me out of everybody else. I think Primas started associating with genetics, if I remember my conversations with Praveen correctly, about 19 years ago, which is as long as almost the sequencing platforms have begun. We began our first partnership with Illumina, which is a global giant in sequencing, holds about 85% of global sequencing as of today. And I think that time, like ma'am said and like sir said, genomics is very nascent and it was very difficult. And at that point, people had to go door to door. Imagine if doing genetics was hard, imagine how hard it was to sell a platform. And for people to believe that you have to bring a white elephant in here to diagnose something more than beyond oncology, think about not just discovery. Today we are talking about clinical endpoints. We were talking about discovery and the possibility of genomics, even at a small scale then. So to go from, I think, billions of dollars in a genome to today talking about and arguing with our clients about whether a genome can be done at $250 or $100 is, I think, phenomenal. I haven't been a part of the 20-year journey, but in 1 year it has been very, very, very steep in terms of the learning curve. And I also want to introduce the fact that because we learned so much at Primas and we believe in what we do, I think we also launched a Make in India company last year called Uncoded. And that's as old as how I am in Primas. So I'll talk about that because that's a baby in Primas, but it's a pretty proud baby because it is believing in bringing home genomic solutions that are made in India, for India. And like Dr. Prashant was talking about, voice of healthcare is by the people, for the people, and of the people in healthcare. I think that's what we are trying to do with Uncoded for India. So I hope I answered that.
Yes, you did.
Thank
So
you.
in fact, I will just have a follow-up question on that. Making technologies in India and empowering India. You see the tables have turned now, where it was so difficult even convinced to do probably one Sanger sequencing. I'm sure me and Dr. Sridhar have struggled to convince the government to give us money for that. Today we have money just poured in for genomics. As now Make in India effort that you're intending to do, what are your priority areas and where do you think we are moving except oncology?
It's, it's funny again, I'll tell you why. Because I am an engineer and I have a PhD in oncology. And today I do clinical genomics as I look at the product as clinical genomics per se for India. Okay, and when I did all of this in my journey, I think my parents were thinking, where is she going? It's the most jugadu kind of degree she's doing. But I feel like just like AI, I have found, I think all the people in this generation are finding their place in the intersection and the realm of the subset of many things. I think where we are today in India is at an intersection of technology, of clinical endpoints, and of data. So I think where we have to move from here for me would be for not to adopt science, because that's not the tough part really. We have to start building workflows and we have to start building systems that integrate within. So to begin with, we spoke a lot. I think it's almost become the poster girl of today that we don't have a reference genome that is Indian data. And I agree with that, because Caucasian data is where we call our reference genome, and a lot of genomic tools were built around it. But we are, if you take the top IT companies and the AI work that's going on, it's either with Indian origin or India associated somewhere, even on the global map. So we need to start building at that scale where we're talking about genomic tools. We already have something called ABA at a government level. We need to start thinking not just about databases, about also making them public. We are not just talking about panels anymore. We are also talking about what variants are for us today, which means it's great to see that European databases have been built, genomic tools have been built. We have multiple knowledge databases, whether you talk about OncoKB, CKB in oncology, or several other splice variant databases, and all of this information over hundreds of databases, but most of them are focused across the Caucasians, right? And when we talk about variants of unknown significance for any disease, do we have a database that houses over 4,600 diversities that comes from the Indian landscape? We don't. So we have to start building on that spectrum that comes in data. We have to start talking about we are not talking anymore about walking in the speed of the lab. We'll have to start walking in the speed of the disease. So our discharge days have to match with our TAT. So it is not that the patient gets discharged in 5 days and we take 4 weeks to give a report. So I think all of these things have to change. Panels will be, India is, like we all say, a jugadu country. So I would expect panels being built, not just like Uncoded as our company, but I think we need to build more companies in that area with more diversity, not just in oncology, but other areas in infection, in rare diseases, in metabolic disorders, also in lifestyle diseases at the moment.
Okay, thank you. Thank you so much. I'll move to Dr. Atul. Coming now from the diagnostic segment, where do you think we need to invest on? Where do you think is the first adoption? What are the low-hanging fruits in diagnostics and precision medicine in the non-oncology segment that we need to start worrying about, or we could start immediately implementing it?
Yeah, I think there are a lot of low-hanging fruits. So it's not one low-hanging fruit, but like it's a tree. So the first thing which comes to my mind is the sepsis market. See, because that is where the first impact comes in a hospital kind of a setting. Today, what we see is the person who is in ICU, time is the most crux for him. And the genomic tools what we have currently in our hand will be able to help them out a lot. Similarly, for smaller panels like a respiratory panels, so gone are the days when we were looking at one organism kind of a PCR. Multiplex PCRs are the talk of the day because of the fact that if a patient walks into into the clinic saying that there is a pyroxia of unknown origin, what does that mean? So we need to find that origin. Also, the other low-hanging fruit could be in the reproductive health segment. Uh, while amniocentesis is on its way out and things like non-invasive prenatal testing and other things are taking over, but still, uh, uh, those are the low-hanging fruits, and those can be adopted to monogenic disorders and help us to expand the menu which is there in a non-invasive kind of a scenario. And the other things which could be there is definitely looking at, as ma'am said, carrier screening. So that is where one should be looking at, because if we are able to prevent uh, the birth of a child with which we know is going to have some kind of a genetic disorder, because cures are very, very less in genetic disorders. Prevention is one of the things which we should be looking at.
Thank you. Thank you so much. I want to move next to the two gentlemen who are here. Um, Dr. Kanishka Jain. Uh, how did you even imagine, where we are talking of genetics and genomics in terms of patient diagnostics, to actually move from a non-clinical space, I mean, into a non-clinical space from a clinical space? What was it? What was it motivation? What was the challenge that you thought was important? And especially, talking about metabolics and metabolomics, reactive pathways.
So firstly, I'd like to thank you for that question. It's a very nice question, and it actually covers a lot of stuff that we have been facing as challenges as well as what we have attacked, and our constant quest to find the correct answer where those answers do not exist. That's what we attack. So when we look at our investigations and our diagnostics, a conventional doctor is told that you look at biomarkers, you're not taught to look at genetics. So on this esteemed panel, there are so many people who have so much more experience than us about genetics, about clinical genomics and application. And we tend to borrow a little bit of their expertise to try to get better and easier solutions where we can apply it on a day-to-day basis, and also to people who have access to a lot of the things that are not accessible to the general public as well. Like for example, you might have somebody who has access to longevity therapies and they don't know how to use it, but with your genetics and your genetic data, you can figure out what kind of application can apply to you, and then basically do a 2-point data set where you do an RNA expression test at the beginning, because we are not looking at people who are inherently suffering from diseases. We are looking not at the patients, we are looking at clients in our journey, and they are looking at improvements. So you're not looking at certain cell markers that are on the downside, you're looking at markers which can improve. And that is very critical, because when we borrow our data also, we do borrow it from cancer, where the cancer cells do have certain good aspects, certain bad aspects, when it comes to receptors, to ligands, to secondary expressions, to gene expressions. And we look at that to apply to prevent these kind of problems, where somebody may have an inflammation marker that's going up, but we can reduce that and then take them multiple steps away from cancer or from diseases. And that has been basically the challenge of how to develop these things in a streamlined way, educate the clients that come to us, and then apply it on a practical level where they can use it on a day-to-day basis without it being a hindrance in their life, and it's an easy, repeatable, accessible thing to do for them.
Wonderful. So we are now moving only not just treating diseases and treating unhealthy conditions, but actually not falling sick. So that brings to my question to Ashim, where you're talking about nutrition and genomics. What do you think is the current status of nutrition and genomics, or what we call it as nutrigenomics to be more fascinating? And what do you think we are heading to?
Back in the day, I'll just step away for this for 1 second and I'll come back to your question.
Sure.
But back in the day, if someone had high CPK levels and they had inflammation, etc., they would have to have deep resources. They would have to be able to travel to South Africa, where NASA has designed an equipment for them, an IVT machine. They'd go into that, they get their results better, and then that's the process. Now you have IVT machines available within the 2-kilometer radius of where we're sitting right now. So things have changed when it comes to nutrition. Back in the day, we never had stuff like liposomized amino acids, liposomized resveratrol, liposomized NMN. You have people who take NMN, who will take resveratrol. You'll ask them, are you seeing any results? And they'll say, no, I'm not really feeling anything. And then even on their, whether it's a blood panel test that you do, or you'll say, oh, it's not really changing anything. But now you know the delivery system has to change, and now the revolution has taken place with that. So things have improved in a very, very good way. And now you have access to all this stuff. At one time, if you wanted to have a liposomized whatever unique thing that is only meant for you, you had to have really, really deep resources to be able to get that. That's not the case anymore. Now, normal people with maybe, without costing them an arm and a leg, they're able to afford that. And the access is there.
Okay, but how do you think, is there a space of integrating genomics?
Of course, that's how we look at it when we look at RNA expressions, etc.
Okay.
We see that, okay, which are the amino acids, for example, I'm making this very specific, which amino acids can actually improve organs or improve processes that we're looking for. And then we know, okay, so you only need, for example, liposomized taurine or glycine. And then that's it. And then that's what you need to hunt for. And you make that, you will notice a difference. And then your longitudinal study that is done on RNA expression will also reflect that.
Okay, okay, great. So I'm getting back to Sridhar here, continuing from there. When we talk about rare diseases, this is something which we are talking about individual patients and patients suffering from single mutations. How well have we progressed it to individualize medicine there in terms of rare diseases, number one? And do you think that's a practical model which is scalable in the country?
So, rare disease was a case in example, I would put it.
Okay.
Cancer is a case in example. Each of them have their challenges and nuances that the clinician and the community needs to take ahead. But if you were to take lessons from this, same with infectious disease, there is a common theme. What applies to the rest of the world probably would not apply to India. We need to bring up our own models. And like a healthcare in our country is largely paid out of pocket, similarly.
Absolutely.
So what will work for India and what really has really worked is, how do you use the test? Maybe the minimum amount of test with a maximum return on the investment. Okay. I think one of the ways that I see things going forward is things like in apparently healthy individuals who take a yearly health checkup, maybe introduction of whole genome sequencing into it as a preemptive test. I know the data is large and everything, but so it's anything new that comes in is a little bit complicated, but I think the return on the investments for right from childhood, from birth, all the way till a super aged individual, there has been very good scientific evidence being built on how to use the data in a proactive manner. So I think that's where the world is headed to, and that's what rare diseases has taught us. Now rare diseases, while the policies exist, most of the people in India seek out clinical help and pay out of their pocket, and it is very affordable right now to sort of get a diagnosis at least. I'm not saying it's easy to get the therapeutics going. That's the next challenge. I'll stop there.
Okay. So, Dr. Atul, what has been your experience sitting in the diagnostic segment about access to these technologies to people beyond that routinely come to our clinics and hospitals? Because this is one of the very small segments that we are catering to. Are we able to cater karyotyping and basic genomic testings for our patients now in the rural segment? Madam, I have a question.
Yeah, I think the accessibility to these technologies have really improved over the years thanks to Dr. Hema and the likes of her. If I look at the doctor awareness of these tests, it is rising. I think it needs to still improve. The labs are able to cater to it, but the information translation between what the lab has to say and what the clinician is actually looking for is a major gap which we still feel. There have been queries like, I have ordered a exome sequencing for a cancer patient whom I am looking at from a somatic perspective. I didn't get anything because the depth was not there. So they don't understand the concept of a depth or all regards to them, but then the gap between the lab and the clinician is still there, which needs to be filled up. Also, if you look at things like whole exome and whole genome sequences are not the answer to everything. Sanger sequencing, triplet prime PCRs, MLPA, and all these technologies are there to fill those gaps. So the clinician should also be aware of these things.
Anjali, what are your thoughts on implementing this? Madam, I have a very specific question reserved for you on the same lines, and you will have the last word.
So I have a simple example for this, which is, why do you think people are not taking the metros as frequently as we think they should? I think it is the same analogy that applies to genomics, which is the last mile, and it's rightly addressed by Dr. Atul, where we do understand that the report comes out. Some people, technology has reached a state where we spent a lot of intellectual quotient on building assays and getting the report, but clinical decision making is still a big gap. And that thin line between the final report, the genetist, and the clinician, and what the final decision has to be about therapy, that is where I think innovation has to come into play now to make it far easier. That also adds to the time of TAT. And that also adds to new adoptions across not just tier 1 and tier 2, but tier 3 and tier 4 where we are going today. Because it's great to have technology, it's great to have data, it's great to integrate this with on-cloud pipelines to get end-to-end solutions and reporting. But think about it, 1.4 billion people, less than 2,000 trained bioinformaticians to do this. Deployment is less than 10% if you look at the math. Right? So to get better deployment, of course we can do AI and build reporting and all of this, but the clinical decision tree still remains a big gap. Of course, with training and awareness, we can get the new inductions in with better knowledge. The people who are pumping into the system right now can obviously come with better awareness and more acumen for better reporting with case study examples already embedded in their courses when they come in. Like, it'll be great to have an MD in cardiology walk in with the knowledge of an NGS panel, right? It's brilliant. But between that and today, we still have brilliant doctors who are waiting to learn, and a lot of them who know much better than all of us do, right? And the gap is between the two populations. Brilliance stays the same, but it's just the clinical decision tree that is still missing. So I think that gap is what changes between adoption for new, and that's the big gap between what tier 1 has today that probably can trickle down to the rural places.
Madam, your thoughts, please.
Can I
Yes,
add
please.
something to the previous questions? Like, you were talking about nutrigenomics, but folic acid supplement periconceptional is the most important thing for prevention of neural tube defects. And normally, like we always say, 2 months prior to pregnancy. So today's cola-sipping girl is going to be tomorrow's mother. So she should be guided that folic acid supplement needs to be taken before 2 months of planning of pregnancy, and that should be kept in mind. And another thing, sir, what you said, that amniocentesis will not go because we require fetal cells, and NIPT is still a very high-end screening test and not a diagnostic test.
So what do you think, ma'am, is the future with the NGS and the artificial intelligence all coming into picture, where you started by seeing the first chromosomes in this country to now seeing the genome data yourself? Where do you think we are heading to, and how are we going to address the point which she made of now making a clinical decision tree? Because it's no more like, okay, now you have a diagnosis and prevention is the way. We need to now move beyond just diagnostics. How should we achieve that? What should we do to achieve that?
Now, I'm looking at from the population point of view, like rural India requires lot of knowledge as far as all the doctors require training, because we have all technology available. Anything can be diagnosed, but we are still not able to reach. So with that, now we have got Rashtriya Bal Swasthya Karyakram. So I go and sit with Anganwadi workers in rural area on my own and take camps on my own and start giving lectures to the medical colleges, so that today's doctors are going to learn what it is, and to the doctors who are there, because they cannot come for such good seminars, whatever we are having, holding conferences. So I think that way it is only now training which is required to our population who are in healthcare, those who are in healthcare, prevention and diagnostic technologies to be offered.
Wonderful, wonderful. Beyond genomics, where do you think how we can apply metabolomics to health, longevity, and diseases?
To me?
And Ashim or Kanishka, whosoever. I mean, I'll leave it.
Can you just repeat that again? Sorry.
The question is that beyond genomics, I mean, I understand this is a very genomics-heavy panel.
Yes.
Where do you think is the application? I mean, let's not apply genomics because I don't think personally that it's something which can be applied to every patient and every person in the country. Do you think metabolomics or metabolic profiling or looking at inflammation-like conditions would be the beginning where we should make and then have a tiered approach in diagnostics?
Because when we build solutions, you're looking at, as Dr. Hema said, it's about a mass level. And then I think the tandem that is there is that you have very specialization things that are going on, and it's hyper individualized protocols that are built for person to person. But on a clinical level, you can't really do that with everybody coming in, because then you can't see a lot of people. So that's the trade-off that's always happening. So with regards to that, you'd have to build a system where you have a low-tier thing that is there, where you prevent most metabolic diseases, for example, and then it would get into specialization on a tier-by-tier approach. That would be there, where your solutions are dedicated based on that.
Okay.
And that's how it would become into a system.
So are our metabolic tools ready to be deployable in the healthcare segment at the primary levels?
So in the primary thing, what we are looking at is we are looking at things that can be applied on a universal basis. We know that protein is something that needs to be prioritized. Muscle is the organ of longevity. And now there have been countless clinical studies to prove that if you have a significant amount of muscle on your body, you will not be having health disorders. So we would build from there. And then once that is being adopted, because there needs to be a significant mindset shift where people are prioritizing their health as not in numbers, but the quality that they get, where you are staying away from disorders, you're staying from hospitals, you don't want to be inside there, you want to be able to live a much more healthier life than what your parents lived, where you are just basically optimizing everything and maximizing your performance in every field of work. And
sorry, to interrupt, I actually want to piggyback what Dr. Hema said. When you talk about folic acid supplementation or any form of supplementation, your genetics make a very big difference because the mode of supplementation changes. Some people are okay with certain capsules, some people are not. And that means that if you're taking, for example, vitamin D, and if it's in the wrong format, it's not doing anything for you. So you need to have it hyper individualized. And for that, we have to come back to genetics at the end of the day.
Okay. Thank you. Thank you so much. I think we are running short of time, so I'll cut short most of my questions, but my favorite rapid fire, and I'll start with Sridhar.
Can I just?
Yes, sure, ma'am.
See, today we are having screening at 4 levels that we have not, summarized. Like carrier screening, so identifying a genetic disorder risk. Secondly, newborn screening as soon as baby is born, not only for the genetics, but hearing and vision, all we can do. Of course, cardiac ultrasound, we are doing it. So these are the things which are to be taken, and then of course prenatal screening. So today genetics is on screening and diagnostic. We have got immense tests available, and training part all you are doing through these conferences. But we have to remember screening first and then the diagnosis.
Wonderful, ma'am. Thank you. So Sridhar, rapid fire. As an academician, one disease that you think we should target immediately now, and your advice for students? Short, quick answer.
Sudden cardiac death, because it impacts everybody, and about 1.4%, that is 1.4 crore people are at risk in the country.
And what's your advice for students who are sitting in the audience?
Get yourself screened. There are only 3 genes that account for 85% of the disease. While there are 37 other genes that are known, 3 genes account for it. So it's not a rocket science to figure out. And if you meet the trigger, you will die. So it's good that we get screened.
Thank you, thank you. Madam, your opinion on which is the immediate disease that we should target as this country, and one advice to the young students here.
Like he's very rightly said, cardiac, then we have got Down syndrome, where screening can be done. And we are having a prenatal diagnosis and asking them to take them as soon as baby is born, to taking them further for improving their intellectual ability.
Thank you. What is one advice for the young students in the audience?
Me?
Yes, what do you advise?
To students. How many of them are medical, having medical background, science background, genetic counseling? So whoever wants to take genetics as a career, they must know how to do genetic counseling. Every single test without genetic counseling, however labs may be there, but if you are not, because lab is not going to know any proper history. So that genetic counseling for 3 generations, vertical and horizontal, you will be able to pick up more cases or more conditions than what you are actually looking for.
Thank you. Anjali, as an entrepreneur, one disease that you would want to tackle and one advice for students.
I think one disease is TB because it has a start, a middle, and an end. And I think we're also in the National TB Elimination Program, so no better time than today for that. What I would advise to students is let's celebrate the chaos we have in India. So please build, because we are at the zenith of everything that is innovating. So please build anything that you can now.
Dr. Atul, your views, please.
So I'll like to pick thalassemia, single gene. A lot of prevention can be done by simple screening. And I think a lot of pain to the parents can be avoided if they are properly done at the career stage itself. So advice for the students, be happy. I think that is going to take us all forward. Be innovative, like Anjali also said, and India is going to do great.
Ashim, where do you think we should head to, and one advice for students?
Everybody's listed out some great options over here. I think we should do something a little different. Stress. I think stress should be attacked, and it's not just a Gen Z thing that I'm talking about. It's that stress triggers a lot of things down the line as well. And because we function and a lot of our work is on the metabolic side, I would go with stress right now.
Stress. And one advice to students.
You'll need to make sure that your dopamine levels are accurate.
Wonderful. Dr. Kanishka.
Yes. So carrying on from that, there is stress, there is the way of feeling happy, and that can be targeted with certain genes which triggered or get triggered when you do a screening with music that you can use to get yourself smarter, to get yourself to feel good, and it does. There is actually measurable reports that will show that you're feeling better on that, and you're getting your dopamine and oxytocin hits, and you're able to be better with your study techniques and everything, and be better as geneticists if you choose to be one.
Great. And one advice for students.
So for students, the chaos is not the problem. Adapting to the chaos is what we are meant to do.
Wonderful. Thank you. Thank you so much. I'm sure we had a wonderful panel who gave us wonderful advices, wonderful insights into things beyond oncology. And I thank the organizers and the panel for that.
Thank you so much, Dr. Deepak. Thank you so much for amazingly moderating this session and making it, a very memorable. So I would like to request to please do the honors and felicitate the fellow speakers for this amazing conversation we had, starting with Dr. Sridhar Sivasibhu. Dr. Hema Purandre. Dr. Kanishka Jain. Mr. Ashim Mathan. Dr. Anjali Pai. Dr. Atul Khatai. I would also like to invite Dr. Naveen Nishal to please come on stage and felicitate Dr. Deepak Modi for amazingly steering this conversation. Oh, we do have so. Thank you, sir. And let's get into center for a group picture. Thank you, sir. Thank you so much.